Welcome to this video on navigating the summer surge. We will explore the critical clinical challenges posed by trauma season and extreme heat, offering a playbook designed for U.S. healthcare systems. Healthcare systems face a predictable seasonal shift. As winter respiratory illnesses decline, emergency departments see a sharp rise in environmental exposure and trauma. Success requires proactively planning for these peaks and transitioning resources towards summer trauma fast-tracking. The 2023 baseline recorded nearly 120,000 heat-related emergency department visits. The danger window is clear. 92% of these visits occurred between May and September, with the risk in July and August being 3 times higher than other warm season months. Summer brings a variety of emergency conditions and accidents, from heat exhaustion and strokes to motor vehicle accidents, drownings, trauma from recreational activities, burns, and foodborne illnesses. Emergency departments must be prepared for a diverse range of high-volume cases. Distinguishing between heat exhaustion and heat stroke is vital. While exhaustion involves inadequate thermoregulation with intact mentation, heat stroke represents a failure of thermoregulation with core temperatures at or above 40 degrees Celsius, often accompanied by severe central nervous system dysfunction. Pediatric populations are especially vulnerable. Data shows a high incidence of recreational trauma and exertional heat stroke in summer months. Due to a higher surface area to mass ratio, children absorb heat more quickly than adults, requiring targeted prevention strategies for youth under 16. Systemic preparedness is key to absorbing these surges. Effective strategies include pre-hospital telemetry for early notification, triage redesign to improve throughput, adaptive staffing to match volume spikes, and dedicated fast-track clinical pathways for common summer injuries. For exertional heat stroke, every second counts. The survival paradigm is cool first, transport second. If cooling is initiated within 10 minutes of collapse, the goal of 100% survival becomes achievable. Do not delay cooling to initiate transport. When a heat alert is triggered, clinicians should follow a clear algorithm. Confirm the diagnosis based on exposure and symptoms, differentiate from other conditions like sepsis, and immediately activate the heat response guide, including preparation of cooling equipment. For cooling, cold water immersion remains the gold standard. Evaporative and convective cooling are highly effective alternatives. Remember to monitor core temperature rectally to avoid overshoot. And remember, the only absolute contraindication is a normal or low body temperature. A vulnerability matrix helps identify high-risk patients. Factors include age extremes, chronic illnesses, medications that impair heat response, and socio-environmental risks like high occupational exposure or living in urban heat islands without air conditioning. Our prevention playbook relies on interlocking protocols. The most critical is acclimatization, gradual exposure to heat. Additionally, clinicians should monitor environmental conditions using tools like the wet bulb globe temperature and promote hydration and heat hygiene among staff. Finally, the prevention ecosystem spans from the individual to the community and structural policy. This includes empowering patients to recognize early symptoms, community-level welfare checks, and broader efforts like cooling centers and sustainable urban infrastructure. This video is based on evidence from organizations including the CDC, OSHA, and recent medical literature. We hope these guidelines assist your system in navigating the summer surge effectively.